Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling a heart defect known as a patent ductus arteriosus. You'll hear this called a PDA. So as always, let's kick things off with our practice question. Tuck that right answer away for the end of the episode where we will review it together. All right, a 6-week-old infant with a confirmed diagnosis of a PDA is admitted for poor feeding and tachypnea. Which nursing intervention best addresses the underlying pathophysiology of this condition? We have A, provide high-calorie feeds through an NG tube to conserve energy. B, place the infant on supplemental oxygen via a nasal cannula. C, position the infant semi-Fowlers during feeds to reduce aspiration risk. Or D, administer scheduled acetaminophen to decrease metabolic demands. All right, save what you think the correct answer is, and let's dive into what exactly a patent ductus arteriosus, or PDA, actually is. First, to understand it, we have to talk about what a ductus arteriosus is, because in this heart defect with a patent ductus arteriosus, we know patent means something is open. We just have this structure, this ductus arteriosus, that is open. So what is the ductus arteriosus? It is a normal fetal structure. Basically, it is a shortcut between the pulmonary artery, that's the artery bringing blood to the lungs, and the aorta, our big artery, bringing blood to the body. So a shortcut, by that I just mean it's a little hole. It's a little opening between the pulmonary artery and the aorta. Why would we want a hole there? Well, in the womb, the lungs aren't being used for oxygen exchange. All right, the fetus is in there floating around in amniotic fluid. They're not breathing in and out, inflating their lungs. So this little opening, we'll call it like a little side road, allows blood to bypass the lungs. It's going to start going through that pulmonary artery, but boom, there's a little shortcut. Let's go through the ductus arteriosus into the aorta. And now the blood is going into systemic circulation, which is great. That's where we want it. Why would I bother sending blood out to the lungs if I'm not using them? Obviously, this changes very soon after birth. When the baby takes their first big deep breath, that shortcut is no longer needed. So that ductus arteriosus, that hole between the pulmonary artery and the aorta, should start to close up within the first 12 to 72 hours of life. So what happens in a PDA? Remember that P is patent, open. Well, that ductus arteriosus stays open. That door, boom, wide open. Blood can keep shunting from the pulmonary artery to the aorta. And because the pressure in the aorta is higher than in the pulmonary artery, blood is actually going to shunt from left to right, from that aorta to the pulmonary artery side. That means that oxygen-rich blood that's supposed to be going out to the body goes back to the lungs. It's like taking a little traffic detour. Cars keep looping back into the same crowded street instead of moving forward to their destination. Now, in the fetus, blood was shunting the other way. We were going from the pulmonary artery to the aorta so we could skip the lungs, we could get out to the body. Why has this switched if now we have a newborn and that ductus arteriosus hasn't closed? Because the pressure in the left side of the body, the systemic pressure that's hooked up to that aorta, went up. It got higher. That increase in SVR now pushes blood from left to right. So left aorta, right pulmonary artery. We have oxygen-rich blood shunting back to the pulmonary artery. So we do not want that happening. That is going to overload the lungs. We call that pulmonary overcirculation. The lungs get flooded with more blood than they can handle. And that is what eventually leads to the symptoms that we can see if the PDA is large enough, which are basically the symptoms of heart failure. So they tire really easily with feeds. They sweat a lot. They breathe fast. They can't really gain weight because eating to them feels like running a marathon. They've already got all this fluid in their lungs. How are they supposed to breathe and eat at the same time? So by 3 months, if infants have a significant PDA and we haven't caught it and repaired it, they are most likely showing signs of congestive heart failure. Wet lungs, they're tiring out, they're sweaty. It is just hard because they have so much fluid on their lungs. The other key assessment finding that you have got to know for your exams is what it sounds like. So we have a very distinctive murmur. A murmur is an extra or adventitious heart sound other than the normal S1, S2, lub, dub. Okay, so this murmur has a specific sound. It is a harsh, continuous, machine-like murmur. Okay? If you remember anything from this episode, guys, machine-like murmur. If you see that phrase on your exam, please connect it to PDA. All right? That is classic. So, key takeaway here. Let's recap it before I tell you my story for the day. We got a PDA. That's a persistent opening between the aorta and pulmonary artery. That's normal in fetal circulation. We've got that ductus arteriosus there. It doesn't close. It remains patent. That's a PDA. We're going to have blood flowing from left to right, aorta to pulmonary artery. It's overflowing the lungs. That is leading to heart failure. And what sound do we hear? A machine-like murmur. So I have a lot of stories of babies with PDAs. I spent some time in the NICU, and if you work really anywhere in peds, but especially the NICU, you are going to see a lot of PDAs. This is up there among the most common heart defects, okay? We'll get to treatment a little bit. Luckily, spoiler alert, it can be treated fairly straightforward, and most of the time, babies go home doing great after getting their little PDA repaired. But that being said, the story that jumps into my mind, actually, I was on a peds floor and not the NICU. It's probably why I remember it better. And it was a 6-week-old baby. He came in through the emergency department because it was the weekend and his pediatrician wasn't open, and mom was really worried about his breathing. He was breathing really, really quick. So she came, brought him into the ED. They admitted him up to the floor. We started asking more questions. And it turns out this baby really hadn't been gaining weight or feeding well since about 2 weeks old. So remember, PDA should close 12 to 72 hours after birth. It doesn't close. Blood starts shunting into the lungs. And by that 2-3 week mark, we're getting signs of heart failure. So he's not eating well. He's not gaining weight. What prompts mom to bring him in is he's breathing really fast. He was significantly tachypnic up into the mid to high 70s. Breathing 70 times a minute, definitely not good. Babies breathe faster than we do, but they should not be breathing that fast. And remember, why is he breathing that fast? Pulmonary overcirculation. Blood is shunting from that aorta over to the pulmonary artery, going into the lungs. It's just like flooding him. His lungs are drowning in all that extra blood flow. So feeding's exhausting. He doesn't want to eat, so he's not gaining weight. I also noticed he was pretty diaphoretic, so really sweaty because his body is hard at work. That heart is pumping overtime, just trying to keep up. The other major exam finding, no surprise, was that machinery-like murmur. So it is kind of a harsh, you hear it continuously throughout the cardiac cycle. And it really does sound like, to me, it's like a whirring, like a rumble from a machine. Feeling his pulses, they were nice and strong. His blood pressure was solid. He was absolutely stable, okay? This was not an emergency situation. Really, the only circulatory thing that I was noticing was how sweaty, and he did look a little bit pale. But other than that, he's breathing really quick. He obviously is not gaining weight, not doing great. So in reviewing all of those symptoms and talking to the healthcare provider, it was determined we should go ahead and do some baseline labs and some imaging. The imaging that we need to do is called an echocardiogram. That is basically a really fancy ultrasound. It is going to allow us to visualize some of the anatomy going on in the heart, and they were able to see for this baby a moderate-sized PDA, which informed our treatment. So first thing we did, start a diuretic. For him, it was furosemide. That's Lasix, super common, and basically we just want to get rid of all that extra fluid. Tons of fluid shunting left to right into the lungs. Diuretics are going to help us offload that volume, decrease our pulmonary congestion, and make it easier for him to breathe. Remember, that pulmonary overcirculation is why he is tachypnic. Now, we also are going to start an ACE inhibitor. For him, it was enalapril to reduce afterload, okay? Why do we want to reduce afterload? Because we don't want the heart pumping against a high systemic pressure. We essentially just want to make the job of the heart as easy as possible so that left ventricle can move blood forward through the aorta instead of having it shunt backwards across the PDA. Now, the other big intervention besides medications that got started right away was dropping a nasogastric tube to start some high-calorie fortified feeds. This baby actually wasn't even back to his birth weight, and he was 6 weeks old. We like to be back to birth weight by 2 weeks old. So he's pretty behind. He's looking kind of puny. He's real sweaty, and it's hard for him to eat and actually gain weight right now with how hard his heart is working. So our job is to try and just make his body rest, make his heart not have to work quite as hard. That's why we're trying to pull that fluid off and reduce that afterload. So by dropping an NG tube, we can really pump him full of calories, help him start to grow and get the energy he needs without having to do the work of bottle or breastfeeding while we're trying to sort things out with his heart, right? So those are the big things we did implement right away while we got cardiology consulted. And they ultimately decided they were going to take him to interventional radiology and do what is called a catheter-based PDA closure. Okay, there are a few different ways we can close a PDA. Ultimately, we've got a hole where we don't want a hole, so we need to close the hole. From least to most invasive, here are the 3 ways we can do that. First, we can use a medicine called indomethacin. This medication is often used in the neonatal intensive care unit when we have a premature infant with a PDA, which, by the way, is super, super common. It only works for kind of smaller-ish PDAs, and this baby had a big enough one and was old enough that we didn't feel indomethacin was going to do the trick. So the next thing is what we saw with this baby, a catheter-based closure. They go into interventional radiology, place a small catheter, and that device basically goes up to the hole and seals it shut. All right? Pretty straightforward as far as procedures go. It is quick. I have had some babies, like I send them off to IR. They're back in under an hour. They knock it out and they usually recover very well. I will say this baby recovered great. The procedure was super successful. And with that blood flow being normalized, he got better really, really fast. Now, if that catheter-based closure had not worked, or if it was too big to kind of seal it shut with that device, then we would go for a full surgery where they place a patch and actually surgically close up that hole. But the point being, in some way, shape, or form, we got to close the hole. There's a hole there. It's letting blood flow through that we don't want. Close up the hole. Option 1, indomethacin, really common in the NICU. Remember that med when it comes to PDAs. Option 2, catheter-based closure. Option 3, full-blown surgery. Okay. No matter how it gets closed, once it's closed, these babies get better really quick because they no longer have all this extra blood going to their lungs. Their heart works more effectively, they can eat better, they gain weight, and that resolves all their symptoms. Breathing slows down. Their circulation is better. They're not pale and sweaty. They no longer have that machinery-like murmur because we don't have a hole that blood is whooshing across. Okay, so it's all about restoring blood flow. Whenever you think of a heart defect, think of that underlying anatomy. How is the blood flowing and how do we get it back to normal circulation? So keep that in mind. Hint, hint, that might be a little bit of the key to our practice question here. We're going to circle back to it. I'll read it one more time, and hopefully now you can get to the right answer and understand why. So remember, we have a 6-week-old PDA. They're on the floor. This is our case study. They are tachypnic. What intervention will best address the underlying pathophysiology of this condition, of the PDA? So what addresses the pathophysiology? Is it providing high-calorie feeds through an NG tube? Placing them on supplemental oxygen on a nasal cannula? Positioning them in semi-Fowlers to reduce aspiration? or giving the scheduled acetaminophen to decrease metabolic demands. What is it? What do we do that addresses the underlying pathophysiology? And I'm not even saying that any of these answers are wrong. Depending on what's going on with your client and what you have orders for, any of these could happen. But which of these actions will address the pathophysiology of a PDA? Remember, the key problem is we've got extra blood shunting from the aorta to the pulmonary artery. That's sending way too much blood to the lungs, which really increases how hard we breathe. So B, giving oxygen via a nasal cannula will help. What it will do is act as a pulmonary vasoconstrictor, helping reduce how much blood flow goes through that ductus arteriosus and relieving the strain on the heart. What it will do is act as a pulmonary vasoconstrictor, which narrows those vessels going into the lungs, so we have less blood flow going through the ductus arteriosus and overwhelming the lungs. That is our primary issue, that shunt. What helps it? Giving oxygen. Okay, looking back at A, giving high calorie feeds, that is absolutely something we do. It is supportive care, but it doesn't address the pathophysiology. Looking at C, putting them in semi-Fowlers, yeah, that reduces aspiration risk, but it doesn't impact the pathophysiology. And D, giving acetaminophen helps with comfort, supportive care, yes, but it doesn't address the pathophysiology, okay? So test taking strategy for you guys. You're gonna get a lot of questions on the NCLEX, on your nursing exams, where all of those actions are appropriate. But read and reread the stem of that question and say, what is it asking me? It wants me to find the intervention that actually addresses the pathophysiology of this condition. For this condition, it's a shunt of blood into the lungs, overfilling the lungs. Oxygen is going to address that. So that's our right answer. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.